Welcome back to EM Rapid. Now we will discuss about balanced resuscitation. So if we have a patient in traumatic shock, what's the initial management? First we should recognize the patient is in shock or the patient might possibly go into a shock. Maximize the oxygenation, and if at all the airway is not patent, intubate the patient and secure the airway. And if this patient is having any life-threatening injuries like cardiac tamponade and tension pneumothorax, identify that and do necessary treatment for that. Establish two large bore IV access to the patient. If at all we are not getting a IV cannula, place an IU access or a central venous catheter. Arrange for blood grouping and cross matching, and if at all required, arrange for a massive transfusion protocol in case of class 3 and class 4 hemorrhagic shocks. Then, if at all this patient is having an external wound, control the external hemorrhage either by a direct pressure or applying tourniquet, and do a E-fast and identify from where there is free fluid in the abdomen or in the chest. Where there is free fluid, identify that. Perform a chest X-ray, a pelvic X-ray to look for any open book or any other pelvic fractures. Do a C-spine survey and radiography accordingly. Ultrasound is playing an integral part to find the free fluid in the abdomen. So previously we used to do diagnostic peritoneal lavage to find if there is some bleeding into the abdomen. But since there is ultrasound now, we are able to find a free fluid through that. And in extended fast, we will be checking if there is any bleeding into the pericardial space or if there is any hemothorax or pneumothorax. So extended fast also will help us to find the source of bleeding. So when it comes to management of hemorrhage, if there is an external hemorrhage or any compressible hemorrhage, we can give direct pressure and control the bleeding. And if the bleeder vessel is visible, we can clamp the vessel by direct visualization. Or if it is bleeding from a scalp laceration or so, we can directly suture that, or we can inject lignocaine with epinephrine directly into the wound. Or if it is bleeding from an extremity, we can apply tourniquet and stop hemorrhage, and we can, in order to prevent ischemia, we can release the tourniquet every 45 minutes to avoid prolonged ischemia. And if in case of pelvic injuries, we can apply a pelvic binder also. And in order to control non-compressible bleeding, we have to first identify that by doing a fast examination or by chest radiography or CT scan. And if this patient is unstable, we have to plan to shift this patient to the operating room. And resuscitative endovascular balloon occlusion of the aorta can be done prior to CT scan if there is massive hemorrhage. So in resuscitation, first we will be resuscitating the patient with crystalloids. So either with normal saline or ringer lactate, we will have to resuscitate the patient with IV fluids. Usually we will be giving only 10 to 20 ml per kg maximum of IV fluids. Then we will not flood the patient with more fluids. Then we will be directly going to the blood transfusion. We usually do not recommend colloids because the effects on traumatic shock is unproven. Blood products should be transfused once we give the crystalloids, and so PRBC, platelets and plasma is given in a ratio of 1:1:1, and if at all we have whole blood, that is preferred. Usually we will not keep whole blood as such, so we have to transfuse platelets, plasma and FFP, platelets, RPRBC and plasma in 1:1:1 ratio. And if this patient is having severe bleed and if we know the source of bleed, rapidly mobilize the surgery team, the anesthesia team, the blood bank, and if at all we are working in a peripheral center and we don't have a surgeon available, we have to plan on transferring the patient to a higher center. And because of thromboelastography, we are now able to find which coagulation parameters is being used up and which is deficient in patient, and depending on that which is missing, we are able to correct, and it will help our resuscitation more easy if we have a tech facility. So now we'll move into the balanced resuscitation. So in case of a trauma, balance resuscitation, hemostatic resuscitation and damage control surgery are the integral part of that, and if we do it correctly, we will be able to save the patient. So what is balance resuscitation? That means balancing the goal of organ perfusion with the risk of rebleeding by accepting a lower normal pressure. Otherwise, it is called as controlled resuscitation, controlled hypotension, balanced hypotension, permissive hypotension, or it is called as hypotensive resuscitation. So, what is that? So, we will not be targeting a normal blood pressure for a patient. If the patient comes with shock, we will be targeting a lower blood pressure for the patient so that the organs will be adequately perfused, and we are not targeting a higher pressure. So as a result, there will be a very low risk for bleeding. So we are reducing the risk of bleeding by reducing the blood pressure. So either we can delay the initiation of fluid resuscitation, or we can limit the resuscitation with fluids and blood products in order to target a blood pressure which is just above 70 millimeters of mercury. That means the systolic BP should be targeted just more than 70 millimeters of mercury, or somewhat around 80 to 90 millimeters of mercury, or targeting a MAP between 50 to 60 in a patient without a brain injury. In a patient with brain injury, we should target a MAP of at least 85 millimeters of mercury. So balance resuscitation is not used in a patient with brain injury. So if in a patient without brain injury, we will be targeting a lower MAP so that the organs will get perfused. So so note that balance resuscitation is contraindicated in case of a traumatic brain injury, and we will be doing it only if the patient is not having a traumatic brain injury, and by doing this we will be targeting a MAP of 50 to 60 millimeters of mercury. So why should we do that? What is the disadvantage of aggressive fluid resuscitation, and by targeting a higher blood pressure, what all disadvantages can happen? So because of giving excessive fluids, the coagulation factors can get diluted, and that can cause coagulopathy. There can be an exaggerated response to the trauma from the injured cells that can cause SARS. Then there is a higher risk of ARDS and pulmonary edema for these patients because of fluid overload. There can be dilution of the hemoglobin and the platelets, which can cause anemia and thrombocytopenia, which can again worsen the bleed. Then there can be electrolyte disturbance, and an overall worse prognosis is there. So we shouldn't aggressively resuscitate the patient with trauma with fluids. So in trauma, because of blood loss, there can be ischemia to the organs, and because of blood loss, there can be coagulopathy also. And in trauma, there can be direct injury to the cell, causing cellular distress. So because of cellular distress, some inflammatory mediators and toxins will get produced. So that can cause apoptosis of the cells and necrosis of the organs. So ultimately, organ failure and death will happen. So why should we apply this balance resuscitation, and why should we target a lower blood pressure? So by targeting a lower blood pressure, we will not be aggressively managing this patient with fluids. So that can reduce the incidence of dilutional coagulopathy. And we can avoid the popping out of the clot. Suppose if there is a site of bleeding and body might have formed some clot in that area, if we are giving a lot of fluids, that can pop out the clot. So that can be prevented if we are practicing balance resuscitation. Then reducing the fluid usage can avoid hypothermia. Then it can also reduce the inflammatory cascade in response to exogenous fluid. And it can also reduce rebleeding. And one disadvantage is that because of this targeting a lower blood pressure, there can be a risk of ischemia to the tissue, and the patient might go into a prolonged state of shock, and that can affect the patient. So there are some disadvantages and advantages, but advantages are more than disadvantages. So permissive hypotension or hypotensive resuscitation is just to bridge the definitive management. The definitive management is surgery and to repair the bleeding site. So definitive management is surgery, but permissive hypotension is just to bridge this. So in a patient with shock in trauma, first we should recognize that there is a shock. Then second step is to find the cause of shock. And the third step is to control the shock. The most common cause of shock in case of a trauma patient is hemorrhagic shock. So if it is a hemorrhagic shock, control the hemorrhagic shock either by direct compression, then practice balance resuscitation and go for the definitive management, that is the surgical repair. So I'll just go through the types of shock and trauma. So because of blood loss, there will be hypovolemic shock. And because of some mechanical obstruction, there can be obstructive shock like in cardiac tamponade and tension pneumothorax. Because of any high spinal cord injuries and all, there can be neurogenic shock. And because of direct injury to the heart, there can be cardiogenic shock also in trauma. So if the patient presents with shock, first we should give 1 to 2 liters of fluid to the patient. If at all this patient's MAP is less than 50 to 60, then give 1 to 2 liters of fluid. And in pediatric patients, we will be targeting 20 ml per kg for these patients. Okay. So there can be response to this fluid. So either the patient might have a rapid response and the blood pressure becomes normal. There can be a transient response, that means blood pressure will become normal for some times and after some time it will patient will go into hypotension, or there will be minimal response or no response to the fluid resuscitation. So in a patient with a trauma, the shock can itself cause a insult to the patient. An ongoing bleed can also cause an insult to the patient. And if along with that, if we are giving aggressive resuscitation to the patient, that can dilute the coagulation factors, that will cause hypothermia, and it will also cause acidosis, either hyperchloremic acidosis because of resuscitation or because of the tissue damage. There will be acidosis to the patient and that will cause the lethal triad to death. And the amount of fluid to be replaced in the patient and the how much amount the patient has lost, we cannot predict that one, but our aim is to restore the organ perfusion by targeting a MAP between 50 to 60, like that. And if there is a need for further volumes, we will not be giving much fluid, then we will be giving blood products only. And if the patient is not improving with that, then we will have to immediately involve the surgeons and plan for a surgery. So this is a lethal triad. If this if the patient is having trauma and if we are not acting well properly, this patient will go into the lethal triad, that is coagulopathy, hypothermia and acidosis. When not to apply balance resuscitation or the controversies to balance resuscitation. So it is, as I told before, traumatic brain injury is a contraindication for balance resuscitation, because here we have to target a cerebral perfusion pressure more than 60 millimeters of mercury and a MAP of more than 90. So in order to perfuse the brain. So we cannot apply this balance resuscitation here. And if a patient is having any past history of angina, hypertension, coronary artery disease and all, targeting a lower MAP can cause myocardial and cardiovascular dysfunction. So these are some contraindications, and other contraindications are if we are practicing balance resuscitation and if we find that this patient is having worsening of lactate, reduced urine output, worsening of sensorium because of hypotension, then we cannot practice balance resuscitation anymore. So how long should we do this permissive hypotension or balanced resuscitation? It is only a temporary measure, and the exact time is unclear, but it should not be done more than 90 minutes or maximum more than 120 minutes, and we should ultimately shift this patient to the OT or do a surgical management, and definitive treatment should be done as early as possible for the patient. So make sure that by doing balance resuscitation, we are doing no further harm to the patient. So we are not giving excess fluid to the patient. So we are not giving more than 2 liters to a patient. We are not, by doing that, we are not increasing the chloride load to the patient, and we are not inducing a hyperchloremic metabolic acidosis to the patient. We are not diluting the coagulation factors. So after 2 liters, if at all this patient requires further fluids, we will be giving only blood products. So we are not diluting much coagulation factors. Then we should avoid colloids also, because usage of colloids can cause profound anticoagulant effect, and it can delay the time of clotting. So another alternative to this approach is a normotensive resuscitation. That means we will be targeting a MAP of 65. So in balance resuscitation, we will be targeting somewhere around 50 to 60. And in normotensive, we can target with a MAP of 65. So if at all we find the patient's MAP is less than 65, we have to give fluids or blood products. And if this patient's MAP is more than 65, check whether the patient is having adequate perfusion or not. If there is a strong pulse and warm peripheries, we don't have to further resuscitate the patient and try to increase the MAP. And if at all this patient's MAP is more than 65, and if this patient is having features of poor perfusion, weak pulse, cold peripheries and all, then we have to manage accordingly. Now we'll talk about hemostatic resuscitation. That means we will have to provide adequate blood components which will resemble whole blood, and so that the patient will be having adequate hemoglobin, adequate platelets and plasma to compensate the blood loss. So aim is to restore or maintain the circulating volume, limit the ongoing bleed, and prevent the lethal triad. So we will be transfusing blood products as FFP, PRBC and platelets in 1:1:1 ratio. And if this patient is in class 3 or class 4 shock, we might require a massive transfusion protocol. That means massive transfusion means the requirement of more than 10 units of PRBC over 24 hours. But we have revised the definition that if this patient requires more than 10 units of blood over 6 hours, then that is also called as massive transfusion protocol. So the latest definition is not 24 hours, more than 10 units in 6 hours means it is coming as massive transfusion protocol. Or if this patient require 4 or more units of PRBC over 1 hour, then that is called as MTP or massive transfusion. So as I told, it will be usually required in class 3 or class 4 hemorrhagic shock. And we should think about massive transfusion protocol, and we should arrange the bloods in blood bank if we are having some massive hemorrhage, like a penetrating hemorrhage or a positive fast, or if we are getting a patient with a systolic BP less than 90, if the patient is having a heart rate more than 120, or if this patient's ICD is draining more than 200 ml of blood in an hour, these patients might require a massive transfusion protocol. So if we are practicing this and if we are giving 1:1:1 ratio of blood products, it can improve the outcome and reduce the mortality. Please note that it can also cause hypothermia. So we can try rewarming the body while transfusing, and or we can give warm blood products, which is sometimes impossible in an acute setting and all. try warming the patient and maintaining the temperature of this patient. Not let this patient go into hypothermia. So either we can cover the patient with warm blankets, or we can shift the patient to a trauma bay, which is a warm area. So for practicing massive transfusion protocol, we should have a blood bank which can cross-match the PRBC within 20 minutes, and which can provide the blood. And if at all we don't have a blood grouping and cross-matching for that patient, we should arrange O negative blood, which is a universal donor. And if it is as O negative is especially required in females childbearing age group. In males, we can give O positive blood also. So hemoglobin should be transfused, and we should target a hemoglobin of at least 7 gram in a patient, 7 gram per DL for a patient without any coronary artery disease. And if the patient is having some coronary artery disease, we should target a hemoglobin more than 10 grams per DL. And platelets should be transfused in order to target a platelet value more than 50,000. And INR, if the INR is more than 2, we should transfuse the FFP. And if this patient is in DIC, then we will have to transfuse the cryoprecipitate. So if the fibrinogen is falling more than 10 milligram per deciliter, we should transfuse at least 10 units of cryoprecipitate. So as I told, this should be done. And other adjunctive therapies like recombinant factor 7A can be used, but in acute trauma, there will be loss of many coagulant factors. So that might not be helpful in just recombinant 7A might not be helpful in acute trauma settings, and it is costly also. Then adjunctive therapy with cryoprecipitate I have already mentioned, and tranexamic acid. After the development of the crash trials, tranexamic acid or the antifibrinolytic therapy is used now. So in acute bleeding setting, we will have to give 1 gram tranexamic acid over 15 minutes in 100 ml NS, and after that we can dilute 1 gram of tranexamic acid in 1 pint of NS, and we should give over 8 hours. Next, we will talk about the damage control surgery. So first we have discussed about the balance resuscitation. Then we have discussed about the hemostatic resuscitation. Now we will talk about the damage control surgery. So damage control surgery involves 4 phases. So if at all we are getting a patient with trauma, in phase 0 or the pre-surgery damage control, first we have to identify that if this patient requires surgery or not. This patient should be transported to a trauma care center, and in that center we should initially triage the patient and do initial resuscitation. Then in the phase 1, we should shift the patient to an operation theater, and we should do the damage control surgery. That means if this patient is having severe hemorrhage, arrest the bleeding, then limit the contamination, then make sure that by arresting the bleeding, the patient is getting optimal blood flow to the vital organs. And operating time should be limited so that this patient will not further go into hypothermia or coagulopathy or acidosis. Then after just by doing that minimal surgery, we will have to go to the second phase. That means this patient have to be shifted to the ICU, and this patient's IV fluid therapy should be given. Make sure that this patient is in euvolemia, warm the patient adequately, prevent hypothermia, and normalize the tissue perfusion, reverse the coagulopathy or acidosis, whatever has set into the patient. And once this patient is stabilized, then we will go into the definitive repair of the injuries. This can be done as a staged approach because the patient might be having different injuries or bone fractures and all. So by doing a staged approach, we can do a definitive repair of the injuries and make sure that this patient is coming back to the normal physiological status. And in stage 4, we can do the closure of the abdominal wounds or any other soft tissue wounds, and any other reconstructive surgeries if at all required. We can do it in the phase 4. So in damage control surgery, what are the indications of that? So if this patient is in hypotension, if this patient is having hypothermia because of the ongoing bleed, if the patient presents to the ER with a pH less than 7.2, or after some time after resuscitation we find that this patient is in acidosis, if there is a base deficit more than 50 millimoles per liter, or if the lactate is more than 5, these patients might require a immediate damage control surgery. And if at all this patient require more than a large volume PRVC and all, these patients will require a damage control surgery. Then after that we will shift them to the ICU, stabilize them, and then we will go for the definitive surgery. So this was all about the balanced resuscitation. So we should prevent the lethal triad. We should prevent patient going to the lethal triad, that is the acidosis, hypothermia and coagulopathy, by practicing balanced resuscitation. And that means we will be giving only adequate fluid in order to target a MAP between 50 to 60 and does not make sure that it does not practice in traumatic brain injury. Then we will be giving the hemostatic resuscitation, give blood products in 1:1:1 ratio, and give massive transfusion protocol if at all required. And then if this patient is in severe acidosis, hypotension and in severe base deficit, then we will have to do the damage control surgery and then resuscitate the patient back. So this is all about balanced resuscitation. Thank you.